Welcome to State of the Science number 2. Our topic today is clinical pancreatic transplant. It's still relevant for the future of type 1 diabetes care. And with us today are David Baidal, MD, from the DRI in Miami, David Harriman, MD, from the University of British Columbia, LJ Chen, MD, from the University of Miami, Colleen J, MD, from Wake Forest, and Angelika Gruessner, PhD, from SUNY, New York. Thank you all so very much for joining us. And I'd like to take a moment to recognize our fantastic sponsors, 10x Genomics, Prevention Bio, IMSICE, Vertex, and Inspiral. These organizations are at the forefront of cutting-edge science, and without their support, we could not bring you State of the Science. You can find more about these innovative companies on our website and at our Ask the Experts series, both live and archived on our YouTube channel. So for introductions, since Mario is not with us yet, but I will start with Dr. Colleen J. She's at Wake Forest. There she is, and she's a transplant surgeon and associate professor in the Departments of Surgery and Public Health Sciences, and she's also authored several publications regarding surgical transplant. Welcome, and thank you so much for joining us. Also, Dr. Angelika Gruessner, she's a PhD from SUNY, and she's a world-renowned expert on pancreatic transplant. She's founder of the International Pancreas Transplant Registry. Recent papers include a review of big data and medical research from June 2020, and the current state of pancreas transplantation in the USA, a registry report from December 2018. Welcome. Thanks again for taking a time from your busy schedules to join us. I wondered if Dr. Gruessner would like to set the stage with your impression of where things stand in terms of the role of pancreatic transplant as it relates to T1D research. What is cutting edge in the pancreatic islet transplant space right now?
Can I share the screen and show some slides?
Yes, please be my guest. There we go. Or maybe the bottom screen.
Okay, this is what I wanted to just show in the beginning, that for pancreas transplantation, we look at 3 different categories. The first one are the simultaneous pancreas kidney transplants, and this is by far the largest group because those are the patients who already developed end-stage renal disease due to their diabetes and needed a pancreas transplant. This is the largest group where already the secondary complications are progressing and where the patients come to us. Then pancreas after kidney, those are the patients who already had a kidney and said it was not too bad. So we take pancreas in addition. And for many patients for a very long time, being on dialysis was really the initial point. I want to get off dialysis. I have a living donor. I take a living donor kidney and afterwards get a deceased donor pancreas. And the third category, which is the closest to my heart, is those pancreas transplants alone, which are still patients which didn't develop end-stage renal disease. And here, very often, those are extreme labile diabetics who come to us because they can manage their diabetes. So we distinguish those 3 categories. And why do we do the whole thing? And this is, I think, a very important slide. We don't want to transplant everybody. We are looking for patients who are not able to manage their diabetes appropriately, who are getting hypoglycemic. And when we put those patients on the wait list, you see what is happening to them. We see quite a high rate of people dying on the wait list, and the culprit is the kidney function. And you see here, those are also the diabetic kidney people waiting for a kidney transplant. The mortality is around 50% at 5 years. This means 50% of the patients waiting during this time are dead. And even those patients who had their kidney function restored through a transplant or still don't need a kidney transplant. Here, those are the patients, the extreme labile patients who really can't manage their diabetes appropriately. And those are the patients which we see coming to us labile. They are, even with all the ultimate methods, with the pump, with everything, are not able to manage their diabetes. And we have physicians coming to us asking for it. And so the rationale, just very shortly, so when you have end-stage renal disease, you need a transplant. People will not stay on dialysis, achieve independence of dialysis and insulin injections, improve quality of life. For many of the labile diabetics, this is a major point. Improve neuropathy, protection from recurrent nephropathy, and ultimately the stabilization of secondary complications. And there we worked in NIH projects for many, many years. And what many people don't see, first, there is a point of no return. If you transplant too late, the damage can't be redone. So you have to be very, very, very patient to see an improvement in your secondary complications. So very often we see after a transplant improvements in secondary complications after 5 years of functioning graft. And this is a little bit where I wanted to show just what we achieved. This is how the patient survival over time since 82 improved. And this just should show, so we almost reach 100% of patient survival at 1 year post-transplant. So we are handling complications quite well. And this is the graft function for the 3 categories and the simultaneous pancreas, kidney, which is the easiest organ where we see the best or the best outcome. But here over the years, what you see is improvement in the outcome. And I was very, very conservative here how I computed the outcome. And those are totally insulin independence. And what you see here with an SBK pancreas, so what you now reach at 1 year, over 94, 95 patients may reach insulin independence. And also at 5 years, 80% of the patients who got an SBK reached insulin independence. This is still what we work on. The solitary pancreas transplants still follow the outcomes in the SBK. But even so, in a PTA, at 5 years function, over 60%, totally insulin independence. And why do we get there? What we see is one problem, the pancreas, to transplant the pancreas, it's a very fickle organ. It is not an easy transplant. We were able to manage technical problems better and better over time. But as you can see here, it is very difficult to further improve. Very often graft thrombosis, things like this in deceased donors, sometimes you don't know what happened. Even if it was technically perfect, you have a remaining rate of technical problems. And what is another major problem is immunological graft loss, but lots of improvement could be done. We are getting better and better in diagnosing what is going on with the transplanted organ. And what you see here, this is the 5-year immunological graft loss. And here you can see also, especially in the SB case, where we are right now, and we see at 5 years, around 8–9% immunological graft loss, which is a very promising outcome over time. So I want to stop here. I don't want to talk more. So I don't want to overdo it, but I wanted to set this as where we are to show we are getting better and better, and lots of work is being done to improve what we do.
Yeah, that's great. That's a great way to set the stage. We do have a couple of questions. Can you see those and maybe read them out and answer them, or should I do that? I see. Oh, here's the first one. I'll just read it out. Marcelo Perosa, congratulations from Brazil, Angelika. You did not mention the subcategory of SPK that is SPLK. Do you have any data regarding SPLK in the IPTR?
Yes, but those are not a lot of cases. I have around 180. There is, I wanted to keep it short. There is one here in the United States. In 2020, there was one case done as an SPLK. Okay. So there are little subgroups which are not very often being done.
Okay. And then from Thomas Klein, do all transplant patients require continual immunosuppression? Isn't that a serious cost in light of the COVID-19 pandemic? Does that make them more susceptible to cancer? Would immunosuppression alone early in the onset of T1D have a beneficial effect? This might be a someone outside the medical field, because I think, well, you can answer that.
Sure. I wouldn't call pancreas transplantation a cure. So, and this is the price you have to pay right now. We are not yet there to really provide tolerance to the transplanted organ. But, you know, the benefit you get from a transplant weighs, I think right now, that you have that what you pay for when you don't get the transplant. And I have to repeat, this is just a group of very labile diabetics. So this is not for everybody. If you can manage your diabetes, fine. If you have no problems with hyperglycemia, no problems with hypoglycemia, you are fine. Then, but those are the people who really start to develop end-stage renal disease, where I would say get the transplant as early as possible before you really continue developing those complications.
Here's one more question from Vishal Parekh. What is the extent and contribution of islet and or exocrine cell death due to stress immunosuppression in pancreas transplant? Maybe we could bring in Dr. J as well.
I think this is better.
I think before we answer that question, I would just like to, so I'd like to thank Angelika for doing such a good job setting the stage. And I think some of my comments will go to answering Thomas's question as well, because it's a very insightful one about, you know, the cost that you do pay for this benefit of transplantation.
Fantastic.
But also should just acknowledge the work of the IPTR that Angelika has dedicated her life and so much hard work to, because I think without the data that's captured by that registry, we wouldn't know half of what we do about pancreas transplant. But you know, I think the question we'll get into in this talk is, you know, maybe pancreas transplant versus islet, but there's actually a more fundamental question being asked here. And I think it's the one our referring providers probably ask most often is, why consider some form of pancreas beta cell transplantation at all as opposed to insulin therapy, given all the improvements that have happened with pumps and with glucose monitors over the last year? And so I think it's kind of important to kind of think about that. So one, obviously in the setting of advanced kidney disease, of diabetic nephropathy, insulin pumps and glucose monitors aren't going to address that. And in fact, transplant in the setting of simultaneous pancreas kidney transplant will replace the renal function and render people free from dialysis. But in fact, even outside of that, there is, you know, with this type of glucose control, there is decrease in the development of subsequent diabetic nephropathy. There can be improvements in some of the sequelae, including like diabetic retinopathy and neuropathy, not just even halting those processes, in fact, can improve those. But more importantly, as Dr. Gruessner has already kind of highlighted, is this more maybe invasive type of therapy, or for those not doing a good job of controlling their glucoses or having problems because they're too good at controlling their glucoses. And so what are the numbers of that? Well, you know, for anywhere from 15 to 40% of patients who have had long-standing type 1 diabetes, so meaning more than 20 years, will develop problems with hypoglycemia. And hypoglycemia can be life-threatening. It can completely deprive you of your quality of life. People can't drive their cars because they're risk of seizures, things like that, because it becomes more and more their bodies become more and more tolerant of it, and they reach lower and lower levels and develop unawareness. And in fact, up to about 10% of type 1 diabetics might die from hypoglycemia. So this by itself is a huge issue. But also importantly, pancreas transplant is a very effective form of glucose control. So if you look at the type 1 diabetes registry, only 70% of pediatric patients, and maybe more importantly, our focus group, adult patients, 21% of adult patients with type 1 diabetes are actually meeting their A1C guidelines. So in fact, many patients do not effectively maximize their medical therapy. And what's intriguing about beta cell replacement in the form of whole pancreas or islet cell is that you are not just treating the highs or preventing the lows, but you're reducing their glycemic excursions in general. And there was a fascinating paper a number of years back by the Mayo Group where they had slapped a number of continuous glucose monitors on patients after pancreas transplant. And in some of these, they compared it to them pre versus post. And so those patients who wore the glucose monitor both before and after transplant, what you saw is that less than 50% of the time were they within this euglycemic range of, like, I think it was 70 to 180 glucose levels before transplant. And now almost 90% of the time they were in that range. And similarly, they compared it to a control group of diabetics who weren't patients being considered for pancreas transplant, because i.e. they were doing well with medical therapy. And they were only spending about 60% of range versus 91% in the pancreas transplant. So I think when you start looking at more sensitive measures like glycemic excursions, you really see how profound a therapy this is. And that is why then you may consider this worthwhile to then take the downside of the risks, which are related to the immunosuppression. So yes, increased cancer rates and increased infection rates. It is important to acknowledge we do have a vaccine for COVID now, and our patients do respond to it, although current recommendations is that they may need 3 doses instead of 2 doses to get an appropriate response to COVID vaccine. But you know, I think hopefully all of these points kind of point to why you would actually want to do something like pancreas transplantation.
Yeah, no, that's well, you really spoke to that. Oops, sorry. I wondered if we could close the screen on the on Angelika's a screen just for a moment so we can see people in a bigger view. There's another, oh, thank you so much. That's perfect. I wondered also if we could take this other question, Tiffany Richardson, how long does it take post-transplantation to regain blood glucose control? Is this a similar time scale to reestablishment of vascular and neuronal connections to the pancreas? Thank you.
The glucose effects take effect right away in the operating room.
Yeah, that's amazing.
Now they are on high dose steroids at first, which makes their initial glucose levels sometimes higher than what we see as they get tapered down on their glucose.
Interesting. I also wondered, you know, for the percentage of, you know, diabetics that are coming in to get the pancreatic transplant, do you see, are some people coming from the type 2 sort of realm and some from type 1? And what is that percentage? Do you have it on sort of that?
Around 20% right now are type 2. And it is very often that you can't distinguish anymore between a type 2 and a type 1 and type 2 when the patient comes with end-stage renal disease. Very few get solitary transplants. But I was talking to somebody in China, which has a very large transplant program, and they were saying 80 to 85% of their pancreas transplant patients are type 2. So it gets more and more leverage to also transplant those patients, which very good results.
It's fascinating. And this was great. I wondered if we could just do a quick poll to our audience. And this is sort of curious about how islet transplant and pancreatic transplant are, you know, getting used or will get used. And I wondered if I'm going to put the poll out now, and the panelists will see it. Here we go. And you can also vote. Will surgical islet transplantation overtake pancreas transplantation? And I'm going to launch that poll. I'll just do it I'll leave it out there for like 30 seconds. I hope you can all see this. And this is sort of just a feedback. A lot of the audience is coming from EPITA, so they are clinically, you know, versed. So it's kind of interesting to see what their impressions are. And I'd love for the panelists to comment on this once we get everyone voted. So people are getting their votes in. So it looks like no. Interesting.
I think right now the patients who you would choose for an islet transplant right now is different than the patient for a pancreas transplant.
Mm-hmm.
So it is complementary. So very often the patient for an islet is a slim patient, very low relatively insulin requirement, while what we see sometimes are the very heavy patients who have a high requirement of insulin. So where the islets itself would be overwhelmed with something like this. Or if you have a patient which has already heavy secondary complications who are too sick for a pancreas transplant, then you would consider islets.
Is it ever the case, or do you imagine this might happen in the future, if someone receives a pancreas and it doesn't, you know, if it undergoes a failure, could they potentially be rescued then by an islet transplant?
Sure.
Anyone? Thoughts? Maybe.
But we were looking for patients who had an islet transplant and afterwards got a pancreas transplant.
Okay. I've got from Rachel Gerlin. Can we discuss thoughts on beta cell replacement for the average non-labile patient? In your opinion, is it feasible in the future that this could be widely available to the majority of the T1D population? I've heard that many scientists believe that this is where the cure will stem from. She's a scientist. Anybody?
depends on the patient.
Yeah. I think that's there is the intersection here between the bench and the clinical world, which is sort of like you guys are in the real interface with patients of many different presentations, and you have to deal with them as they come in.
Well, if I can take that question also very briefly.
Sure.
I think that clearly a cellular replacement strategy, optimally, we would like it to be a cure. But as long as we have therapies that require immunosuppression, there needs to be a clear justification and patient selection. So as an endocrinologist, if I have one of my patients who doesn't have increased lability, I would hesitate to subject them to a procedure exposure to immunosuppression if other technologies and treatment therapies are able to stabilize glycemic control. So there needs to be also, again, patient selection and a careful balance weighing benefits versus potential problems undergoing immunosuppression or receiving a cellular transplant. So I think at the state where we currently are, islet and pancreas transplantation are clearly unique alternatives for a select group of patients. But in patients who do not have lability, but otherwise stable, at this point, having an appropriate cure will require minimization of long-term complications. And as long as we require exposure to immunosuppression, it will be difficult to justify a cellular therapy in somebody who doesn't have increased glycemic lability, and a strong reason for them to undergo that sort of intervention.
Yeah, I totally agree.
Yeah, that's well said. Here's Javier Kochnik. Hi from Chile. Thanks for organizing this activity. How are you guys motivating the diabetology community for early referral for transplant before the patients develop ESRD and get referred to nephrology?
So I think the answer to Javier is we're still struggling to maybe do that to some respect. So as I think Dr. Gruessner already kind of highlighted, the majority of pancreas transplants that are currently being performed in the US are simultaneous pancreas kidney. So about 80% of the about 1,000 we're doing. And there's been a pretty significant decline in the last couple of decades until maybe about 2015, and we've seen a stabilization. I know Dr. Harriman can maybe speak to what it's like in Canada. But I think like understanding who is the pancreas transplant alone patient that will greatly benefit is maybe something that as a community we're still working to educate the public about. And I don't want to speak to islet transplantation because that's not my area of expertise. But it is mindful that they do need to be appropriately selected candidates. There are surgical risks. There are certainly, immunosuppression related risks. And you also need a patient that can comply with the post-transplant care. We're just going to make them worse, not better. But I think it is important to maybe further develop that awareness and those relationships with our referring providers.
Yeah. There's always room for improvement in every field. And so, yeah, it's and with patients, I think that has a special challenge because people don't always comply and so forth. But I think that as you suggested, if you select the right patient, then things, and the data suggested things go well.
Yeah, and both Dr. Harriman and Dr. Chen probably have some further insights into this because we all practice in very different geographies.
Yeah. Do you want to weigh in?
Yeah, I would just say up here in Canada, it's the exact same issue. It's a lot of patients who may benefit from transplantation don't always get the referral in to us. So we do a lot of outreach where we're talking to nephrologists, endocrinologists about the potential benefits of transplantation. So I think that's something that we're always trying to look to expand and to try and provide great service for the people who may benefit from such an intervention. And I just wanted to say a little further on what Dr. Vidal had said earlier about islets for the non-labile diabetics. I completely agree with him. When you have to use immunosuppression, that's a very problematic intervention with potential tremendous medical issues for that patient. In the scientist community right now, we're trying to move towards immune tolerance, where you can give an intervention such as an organ or tissue without the body sending that same immune response. And we are so far away from figuring out how to hide organs from our immune system right now that that's many, many years down the road where we might be able to consider an intervention such as that. But really and truly, all of these things where we're transferring somebody else's genetic material into another person, it does come with a lot of consequences because of the interventions we need to do to protect that material.
And I think in Miami, what we see now is primarily patients who come to us once they've reached end-stage kidney disease. And so we're doing mostly simultaneous pancreas and kidney transplant. We mostly only do pancreas alone after failed pancreas in someone who's an SPK. And we don't really get referral in for pancreas alone these days. And so there needs to be, I think, a lot of education in the community. But pancreas transplant is a different beast. And when you consider that there's always 3 risks, and there's a medical risk, a surgical risk, and an immunological risk, I think I agree with the panel and David in that, you know, just to transplant all T1Ds, unless they're in a labile state where they're not really seeing those really highs or lows, is, you know, you have to consider the patient, and patient selection is very important in terms of the risk of not only immune suppression, but many of these long-standing diabetics have significant advanced cardiovascular disease. And so that definitely is going to play a role in terms of, you know, the surgical risk and getting through, you know, the complications. And then, you know, simultaneous kidney pancreas transplants, we find require, you know, long-term steroid use and, you know, a higher level of baseline immune suppression throughout. And so that should not go unrecognized in terms of, you know, transplanting all T1Ds. And so I think I would also agree that, you know, we tend to stick to very labile patients. I know that many patients come in and you ask, well, have you ever been on glucose, continuous glucose monitors or insulin pumps? And I think at least in our area, there's a trouble with insurance companies covering that. But, you know, as technology improves over time, I think that you will see more a widespread use. I hope, that's the hope. And that, you know, a very, or more better, how I say, or better controlled, you know, diabetes over time, and tighter control, and hopefully we won't see so much, you know, complications in the T1D population.
Yeah, and there probably are some downsides to even the better pumps, you know, so many of our patients have advanced retinopathy. So vision is, you know, something that can affect their ability to cope with those technologies. There's a latency effect between the sensing and the delivering, even in some of the closed loop systems, and the glucagon systems are not widespread available by any means. And also glucagon has a short half-life, so it's a little finicky to be delivering that through a pump. I think, you know, Dr. Harriman's point is a great one about, you know, foreign genetic material in your body. And I don't know that the field is ever going to get it. People are working on this. So I don't mean to be dismissive of their research, but I don't know if our field is ever going to get there where you figure out how to prevent the body from rejecting foreign material without there being immunosuppression in the mix. But perhaps our folks in regenerative medicine one day will figure out how to use the patient's own material to repopulate their beta cells. It's just that's not a therapy that's available here in the near future, even much less prime time now. You know, and even our folks who are working hard, and Dr. Bidell, I welcome your comments in the field of islet transplantation. Like without their work, that field wouldn't be moving forward, but they haven't yet succeeded to the gold standard of whole pancreas transplantation in terms of long-term outcomes and durability of being insulin-free. You know, they are seeing those outcomes in some patients, just not at the degree or level that we see with whole pancreas transplantation. The other reality is it just maybe takes more donors to do islet transplantation in terms of a lot of folks get more than one pancreatic. So perhaps it's a bit more efficient currently to do whole organ pancreas transplantation just in terms of the donor supply. And if you want to consider the cost of that, those kind of things.
We are following, we are following now, I think, around 8,000 patients, which we have with more than 20 years of total insulin insulin independence. So, which is very interesting, and we are getting better and better looking at what was happening there and how we reached this goal. But I have to say again, those are patients who could reduce their immunosuppression a little bit. And what is very very often used is steroid avoidance protocols, which is good for the pancreas. But I see after 10 years, it was not so good for the kidneys. I see problems in the kidneys later on in those steroid withdrawal patients.
I can comment, but I don't know, maybe we should let Monica continue, but I can certainly comment a little bit more for the.
No, please comment. And then when I do the next poll, I actually want to introduce the 3 panelists that didn't get introduced.
No,
because we were imagining that we would have just, the introduction of the anchors and then the panel. So I definitely want to give you guys, a backstory. But yes, please comment, and then I'll do the second poll.
So first of all, I think the interaction has been unique, and I welcome all the comments. And I think overall we're all in agreement and we're all on the same page in terms of islet transplantation and pancreatic transplantation. I don't think it should be as competitive as Dr. Gruessner initially mentioned. But I don't think one will overcome. The role of islet transplantation is not to overcome in any shape or form pancreatic transplantation. I think the outcomes that you can obtain from a complete organ transplant are unique. But as well discussed earlier on by Dr. Gruessner, there are certainly scenarios where the patient is not a good surgical candidate, or it's just preference. The patient may not want to undergo a major surgery. And on top of that, some of the limitations that we currently have is sourcing that may be overcome with the development of stem cell islets, correct, where we have enough cells and we can just expand them on demand. So those are the advancements that are also being looking out in the field of islet transplantation, and clearly may provide an option to patients. So I think the more options we have available to patients that the patients can actually look into, depending, of course, of patient selection, is unique and it's good for our patients, right? They have the abilities to select also the opportunities or the treatment options. But clearly, pancreas transplantation has this unique history, and I think it's advancing very nicely. Surgical techniques have gotten better, and you get the whole organ, and lo and behold, I mean, you are insulin-free with excellent outcomes. We do have also advancements in islet transplantation. In selected centers with expertise, we do have insulin independence rates of about 50% at 5 years, as shown by Dr. Gruessner, about 60%, I think she mentioned, at 5 years. Islet transplantation can also achieve insulin independence rates of about 50% by 5 years. And another important aspect, looking at it with the cap of an endocrinologist and diabetologist, is that to me, the ultimate goal here, and to all of us, is not necessarily insulin independence, but rather metabolic control. And clearly, if you still have C-peptide, and we have shown that if you have a fasting C-peptide, this is data from the clinical collaborative islet transplant registry, more than 0.3 nanograms per milliliter, your outcomes in terms of clinically meaningful outcomes, which means A1C less than 7%, absence of severe hypoglycemia, you can obtain that in up to 80% by 8 years. In islet transplant alone recipients, I mean, I'm not talking about islet after kidney, which unfortunately outcomes is not as strong or as good as islet transplantation alone. So I think the field of islet transplantation clearly is also moving forward. And again, but I don't see it as something that will overcome pancreas transplantation. They're complementary in selected patients, and the more choices patients have, the better. And the other brief comment that I quickly wanted to make is about advanced diabetic technologies. So yes, although patients with type 1 diabetes fortunately have seen this advancement in diabetes technologies with hybrid closed loop systems, algorithms with CGM, and accessibility to these technologies. And I see this on a frequent basis, and the huge impact that it has in improvement of glucose control and the reduction on severe hypoglycemic episodes. The limitations that still remain are device burden, the stigma of carrying a device, problems with insurance, having the sensors approved, sensor failure, you're still using the subcutaneous route, sites of infusion, lipohypertrophy, problems with the insulin, the fact that it's still a hybrid closed-loop system that requires patients to bolus before meals and matching correctly your insulin to your carbohydrates at the right timing to prevent your post-glycemic excursions, problems with the site, you name it, unfortunately. Some patients do phenomenally well. Some patients, unfortunately, have to overcome all these barriers, and some patients just get exhausted from dealing with all the alarms and the technology and so forth. So a cellular transplant can clearly get rid of all of that, stabilize glucose control, and provide that peace of mind and increase quality of life. So there is a niche for both as they work in tandem. So I just wanted to highlight that there's clearly a benefit from these advanced technologies, but there's also the group of patients in which it would just that, independent of that, they will still have lability problems. And the moment that the CGM doesn't work, or they stop the pump, they will be at risk of severe hypoglycemia if they're hypoglycemic unaware.
Yeah, no, that's a very important point, that there are, it's not a one size fits all, and that there's many ways to better health for people with type 1 diabetes, and probably 2 as well. Let me just I'm going to do, thank you for that. I'm going to do a quick second poll, and hold on, I think I'm not going to do that. Poll 1. Well, maybe I'm not going to do that. In the meantime, here we go. Sorry. The second poll, and then while people are polling, I'm going to introduce the 3 other participants. So poll number 2, is the role of pancreatic innervation something that pancreatic transplant surgeons should pay more attention to? And I'm going to launch it. And as we do that, I'm going to discuss, or I'm going to introduce Dr. David Vidal. He's at the DRI University of Miami. He's assistant professor of medicine and division of endocrinology. And he's also a clinical scientist participating as a principal and co-investigator in trials of islet transplantation and trials aiming at preventing development of T1D and minimizing loss of C-peptide in new onset T1D. David Harriman comes to us from Canada, University of British Columbia. He's a fellow. He had a fellowship trained in abdominal organ transplant. He's currently part of the UBC Faculty of Medicine as assistant professor in the Department of Urological Science. And he was 2 years at North Carolina Wake Forest Baptist Medical Center, an accredited American Society of Transplant Surgeons. He worked closely with Dr. Giuseppe Orlando and Dr. Colleen J. So Dr. LJ Chen is an accomplished kidney and pancreatic transplant surgeon who conducts transplant from ages 0 to 70 plus. And she trained in transplant surgery at Stanford and currently practices at University of Miami. And I apologize for not introducing you earlier. Okay, so the poll, let's see the poll. Looks like no, you don't need to pay, you don't need to pay attention to the innervation of the pancreas. And I noticed that was also in our chain of questions from the audience. Okay, would you like to comment on that? Would anyone like to comment on why the innervation is not that important?
Yeah, I guess I'm perplexed by this question. Like, the pancreas graft doesn't come with like a nerve of size that would be suitable for sewing if one was going to engender that idea. But it does begin sensing right away. So it is responding to the endocrine stimuli through the body that doesn't require any gross nerves to be surgically anastomosed. I don't know if the other surgeons have a comment, because I think I'm interpreting the question correctly, but I wonder.
I was a little confused about that because, we're interested in the insulin excretion, and that's endocrine. So I would think that it didn't matter where you put the pancreas, nor does a nerve come with the pancreas. And then second of all, the exocrine function is usually controlled, at least in our center. We do enteric drainage now, but certainly when we did bladder drainage, that negates any concern for the enteric drainage. And so, no, I don't think that we need to be concerned too much about, neural innervation to the pancreas, as far as I understand the physiology.
Yeah, it's not a common part of any whole organ transplant, to be fair. It's not something we do with kidney or liver either.
Yeah. However, in the actual natural state, it is innervated, correct?
Yeah, but I think that a lot of that is sensory, and there's sort of this idea that your transplanted kidneys, well, I was thinking of kidneys, so that's why I said it, but organs can't hurt because we denervate them when we take them out.
Mhm.
But in fact, at least the cavities that they're with can hurt, so people get graft pain when their grafts swell and things like that. So I'm not even sure what to say about that. But in terms of its function, both in stimulating the endocrine secretions like insulin, glucagon, that all carries forward without doing any kind of surgical work to address the innervation. And similarly, as Dr. Chen pointed out, it still makes exocrine, much to our dismay, I guess, because we don't really want it to make the exocrine juices. But in fact, it still makes plenty of the exocrine secretions too. So then you just have to find a way to deal with that drainage, which has been pretty well established now surgically.
So it can go on autopilot. It doesn't necessarily need its innervation. Okay, so I guess that answers that question to people. And then I guess Peter Sr. is coming from Edmonton and he has a quick question. We have people who have moved from islet to pancreas transplant and vice versa in Edmonton, he states. And he also says, we may need to be careful about endocrinologists functioning as gatekeepers. PWD have lived experience and that may not be perceived by providers. What do you think about that? Patients with diabetes.
I'm going to answer the second part of that. Some of our pancreas transplant alone patients are the most grateful patients ever. And I guess as a community, we perceive their benefit the least, right? Because they're not getting saved from dialysis by a combined kidney transplant. But in fact, their quality of life benefits are huge, and they'll tell you that. So I think that is where, wisely as a scientific community, we're starting to focus more on patient-reported outcomes. But I think that goes to, I'm guessing it's probably Dr. Senior's comments. Certainly the Edmund group knows far more about islets than I do, but maybe Dr. Vidal can answer the other part of that.
No, the most patients for solitary pancreas transplants are self-referrals, while for SBKs, the nephrologist refers the patients. But very, very few endocrinologists refer patients for solitary pancreas transplants.
Okay, one more from Peter Sr. Do you think pancreas transplant outcomes should be approached using an intention to treat analysis when considering long-term outcomes? Lots of organs are declined, technical failures excluded, question mark. What do you think? Anybody?
We looked at this and we looked at the outcome when we started. Sometimes when you do the analysis, the question is, at what point do you start? And we did analyses where we started at the point of registration for a transplant. And what we see there is that actually it saves quite a lot of patient years when you do the transplant. When you start at the time of transplant, you already lose the information about the patients who died on the wait list. So those are the things you have to take, especially for the solitary pancreas transplants, into account the patients who died of hypoglycemia unawareness. This is a huge problem, and not a lot of people are talking about this, what we lose there. And so this is actually quite impressive when you look at those analyses where you see what you actually gain also for the solitary pancreas transplants. And in the PTA, the mortality after transplant is the lowest of all transplants, transplanted organs. So we are doing there quite a good job. It is almost 1 year patient survival, 100%.
That's
so it
amazing.
is not as dangerous as it was years before. Surgeons know now what they are doing. And you have to take this into account for those kinds of labile patients. And for those PTAs, as Dr. J was saying, it is a miserable lifestyle.
Yeah, I do think that, in terms of the patient experience, I think Beyond Type 1 recently highlighted a young patient who had this hypoglycemic unawareness, and she underwent the pancreatic transplant, and her quality of life improved dramatically. So I think that really illustrates a real, I mean, even young patients can experience this. It's not just sort of older patients who's had it forever, and it really does increase their quality of life. So thank you all for being part of that. I'll do one more poll because we're getting towards the end, and let's see if I can get it. Sorry. How's this going? Here we go. The last one is, what is the ideal physiological space for islet transplant? And this actually is in the questions. And we have portal vein, subdermal, omentum, and other. And there's a lot of questions peppered through the chat and through the actual Q&A that are asking this also. So I'm glad it's on our roster. And so, yeah, as surgeons, it might be very interesting. You know, I'm very interested to hear your perspective. Okay, portal vein is winning 53%, with about half the people voting. So yeah, let's just say it looks like portal vein is way ahead. I thought omentum might be up there. What are your thoughts on this? Anybody? Dr. Bidal?
I'd be happy to take that. I don't think we have an answer to begin with. I don't know which one is the most physiologic place. I would start by saying that the optimal site at this time is certainly the liver, is the portal vein, because we have all this data and it works. But clearly it's not ideal. I mean, we're still looking for an optimal site, which we have not been able to identify. We have certainly have efforts here at the University of Miami where we have explored the omentum, and we have been excited to see that we do have long-term function in the omentum. But the way that I see an optimal site, it needs, if it's intravascular, it has advantages. You have immediate blood flow within the intravascular compartment, but there's the caveats of reaching an intravascular compartment with the risk of bleeding. And then the space is really a constraint. If you're going to put a significant mass of islets, you're going to be limited by how much volume you can infuse in this restricted and how much compliance you have. So taking that into account, volume, space, bleeding risk, then an extravascular site would be ideal or would be something to highly consider, with the caveat that if you look at an extravascular site, the site needs to allow for quick vascularization and also appropriate diffusion of nutrients, oxygenation, which is a problem. If you don't get quick angiogenesis of the graft, you will lose a significant amount of cells. So either therapies that will improve that or already implanting something that is pre-vascularized are some of the options. And then, of course, you need to have enough space. Ideally, an extravascular space is also interesting because you could potentially go back to provide more cells or to introduce therapies that may allow for engraftment or for tolerance induction later on. So you can actually come back to that particular site. It's more, you can manipulate it better than going into an intravascular site. The omentum, again, is a site that we are still exploring. It has certainly worked. It is not superior at this point in any shape or form to the liver. So I think the question still remains, which is the ideal site? But at this point in time, the liver is still certainly the place to go with the islets. Whether it will be the one in the future, we don't know. We'll keep exploring.
Yeah, I did get one last question from Jonathan Friedel. Can you do the omentum percutaneously?
Absolutely. Yes, actually, we do it percutaneously. That's the approach. And indeed, it's a minor surgery. It's easier on the patients. But one important thing, we can do percutaneously also transplantation of islets in the liver through the portal system. Mm-hmm. So from the perspective of percutaneous approach, it can be done both ways. Both of them can be done percutaneously. But again, the advantage is from the perspective of the bleeding risk, and you have more space, but you're constrained by the fact that you need to have quick vascularization. That's a problem because some of the islets clearly, a significant number may die because they do not get vascularized and they're not in an intravascular compartment.
Well, I'm going to say here, I think we're gonna stop. We've had so many questions and so much interest here, tons of questions and tons of Q&A on both chat and Q&A. And I think we'll stop here. I'd love to invite you all back when we do our second series. We'll start in the fall for another clinical discussion. I just think this is a fascinating frontier, and I laud you all for everything you're doing in terms of saving people's lives and with pancreatic transplant and exploring the islet transplant space and putting it all together. You're really, you're an amazing group, and we really appreciate you speaking today. So thank you again. Look forward to speaking again in the future, and thank you so much.